Good evening, colleagues, brothers and sisters. Let me say a big thank you for having me on today on this webinar. I'm told that I have 35 minutes. I'm a stickler for time, so I don't know if that still stands. Please let me know if that still stands so that I know how to navigate my slides, and because the slides have been many, but I can skip some if time will not permit. But I don't know. That's what I was told. I was told this very late after the slides were done before I was told it's 35 minutes. So I don't know if that still stands. Please let me know.
Yeah, yes, I still stand, sir.
All right, all right. Like we say in research, there's never anything like not enough time. You just work with the time you are given. So I'll work with 30 minutes, 35 minutes so that we can round off. As advertised and as shown on the screen, we have seen the topic, advances in management of cerebrovascular accidents, where we are in Nigeria. My affiliations are on the screen. Let me say I extend courtesy to all those who are on today and those who might listen to the recorded program later. But can we have the next slide now? I have no disclosures to make other than say that I'm doing this for the Western Zona CMDA Western Zona group, and which I proudly belong to. Now the outline is as shown. I'll be looking at key terms. I'll be looking at an overview of stroke, because even though we are looking at advances, but we must know what we are dealing with today. So I'll be looking at the overview of stroke, just a brief overview of stroke, and then of course I'll be situating Nigerian stroke care to what is the best global practice, and then probably fit questions. Next slide. Now, this is our emergency unit in UBTH. This is the portal of entry of all stroke patients. So I chose to show this because this is where it all starts. A patient comes with a stroke, you have to go through this place. 9 out of 10 times they all pass through here, except the few that we admit from the outpatient clinic, but usually for disabling strokes, they come into this portal, this channel. Next slide. This is our stroke ward, the inpatient stroke ward. Once they are done with the emergency ward, everybody lands in here, or the intensive care unit, which is a stone throw from this ward. Next slide. Still on the stroke ward, this is the lobby. Maybe this is the lobby. That was the lobby of the stroke ward, still shown again. Now this schema is sorry, maybe you're a bit too fast. Can you go back one slide, please? Just one slide backwards so that I can talk on the schema that was shown before. Yes, this schema it conveys a message, and I'm sure anybody looking at this can make out something from this, that the ball that is being cracked by the sledgehammer causes stroke. I'm sure if they give anybody, even a wizard, a wizard, when I mean like somebody who's a genius, I should say, a glue to fix back the broken spicle and pieces, the splinters of this group, he won't be able to do it completely. And that's what stroke does to life. So stroke's like a sledgehammer on a ball, on a very fragile ball of life, and it cracks it. And most of the time, recovery is not complete. Next slide. Now, just a bit of definition. We define stroke as a focal neurologic dysfunction, presumably vascular in origin. That's the clinical definition of stroke, that lasts 24 hours or results in death. That we held that on since 72, WHO definition of stroke. But sometime about a decade ago, it was reviewed by the American Stroke Association, American Association. They did a review of that definition, and of course, that changed the outlook and the scenario as far as stroke is concerned. Now we look at stroke in a more objective manner. There is a focal dysfunction, correct, resulting from an infarction or a hemorrhage that is not traumatic within the defined vascular territory, now involving the brain, the retina, or the spinal cord. So no longer a brain issue alone. Time was, we thought all of stroke was about the brain, but that has since changed. Next slide. Next slide, please. Yeah. So no longer a brain attack. And now if it presents under 24 hours, we say it's a transient ischemia. And from this modification, we're now talking about silent infarct and microbleeds without manifest clinical symptoms are also called stroke. So strokes don't have to manifest itself right now. And this definition now changed the prevalence of stroke, and figures had to change because things that ordinarily would not pass for strokes in the past are now called strokes based on this new definition. Next slide, please, for time. Now, this is how we classify strokes broadly. It could be ischemic or hemorrhagic. I'm sure most of us are used to this. Large thrombotic strokes, lacunar strokes, cardioembolic strokes, ischemic strokes of unknown origin, known and unknown origin. Next slide. Hemorrhagic strokes could be intracerebral bleeds or subarachnoid bleeds. Next slide. Now, these are facts and figures. On a global scale, it ranks second leading cause of death, only second to coronary artery disease. Of the WHO 10 leading cause of death worldwide in the last decades, it ranks as number 2, except 2021 when COVID-19 came and overtook stroke and ischemic disease. But ever since that time, is ranking as number 2 behind just coronary artery disease. Both of them account for about a third of the deaths we see worldwide. Stroke alone accounts about 7 million deaths. Ischemic disease about 9 million. And then the disability that it causes is also enormous. You can say about 143 million disability of adjusted life years, which is the burden of stroke. That's a metric for measuring the burden of stroke is huge. But back home in Africa, that's a global scale. We found out that the age bracket of those who come down with stroke is a lot younger than what we see in other climes. Studies from UBTH Benin, which I will show shortly, and of course with Senegalese, which we worked with some 2012. We had a stroke research team in Senegalese. Our partners in Senegal, in collaborative research, we found that there are younger patients, younger folks come down with stroke in Black Africa compared to what obtains in the West. Next slide. Next slide. Now, these are incidence and prevalence figures. You can see these are African figures. I like to come back home. You can see this prevalence is about the highest in the world. These are figures that are way higher than what obtains in the States, in Europe, in Asia, even in the Caribbean islands. Africans rank these are very high figures. But anytime you post this in global meetings, people shout. They wonder what's happening. Next slide. Now, just to come back home, I like to they say charity begins from home. Facts and figures. Our stroke unit in Benin is the oldest in Nigeria since 2010. Now we admit on average 1 new disabling stroke per day. We admit a disabling stroke, and by that I mean patients who have NIS2 score of above 6. As of last year alone, the last 2 years, 400 patients per year, and that ranks us higher than most other centers. And then, of course, ranks us as one of the leading inpatients, the leading number of inpatients on admission in the entire hospital. And then, of course, now we have a new structure after we left our old makeshift structure. We work with about 5 consultant neurologists. Next slide. Now, this was our stroke registry in Benin, published in 2016, but we updated this yet unpublished. This is click ready. This one will tell you about what the picture was like around in our first 2016, first 6 years of the stroke ward, but we since moved on. Next slide. The next slide shows the admissions in 2015. You can see that it's on the rise. Except 2021, where COVID-19, we were not, the wards were shut. Otherwise, is on the rise. And now that picture that was before COVID-19 is back again. You can see that we now do as high as 400 patients per year since the last 2 or 3 years after COVID-19. This is from the UBTH stroke world. Next slide. Now, risk factors for stroke, most of us know this, non-modifiable age, advancing age. After age 45 years, you are no longer young. The risk of stroke doubles after every decade. Family history, especially maternal history. We now know that the genes, you are your biology. So you must watch your biology, your gene. You are your gene, as we say in genetics, you are your gene. You can't run from your gene. So there's a genetic predisposition to strokes, and certain genes are known to have more than a chance association with a stroke. And the saying is correct that your genes, you are your genes to a large extent. Next slide. Now, risk factors that are modifiable, I had to circle the ones in red ink because these ones, WHO will say that this one in red, the ones in red ink account for 2/3 of all stroke patients who have one of these ones in red ink. You will see that hypertension takes the lead, sugar diabetes, cholesterol, high cholesterol levels uncontrolled, atrial fibrillation, alcohol consumption, tobacco smoking. These ones, if you look at most in our own series in Benin, 9 out of 10, more than 9 of them out of 10 will have one of these risk factors. Of course, sickle cell disease in pediatric age group, and of course, alcohol use, and of course, recreational drugs. Nowadays, we see 45 marijuana like Eyes and Loud. We're also seeing young men coming down with strokes now. Next slide for time. This is a schema showing what I just said just now on the risk factors of stroke. You can look at, everything that I said just now is now in a schematic form. Next slide. This is the common stroke symptoms. We talk about the fleas. The fleas talks about common stroke symptoms. But what I will say here quickly is that if you see when stroke comes, like if the symptom of stroke is usually a negative symptom, we'll say that stroke will not give you. Stroke will either cause you a loss. You're either losing a speech, or you're losing an arm, or losing a limb, or losing a function. Stroke is always negative. So stroke will not make, for example, stroke hardly will give you excessive movement or dyskinesia. Stroke will leave you with a loss. So if you see that the speech is, you're losing speech, you're losing arm, you're going blind, or losing a leg, or your face is getting contoured and twisted, think about the stroke. Or stroke will always give you negative symptoms, and usually is complete from the word go. Rarely it can also evolve. Next slide. Now, the concept of acting fast in stroke, I brought this up because stroke is an emergency. Symptoms involve quickly, delay in presentation, denies potential help, and current recommended treatment modalities available are time sensitive. We'll see that as we progress. Quick referral to a stroke center is the ultimate, is recommended. And treatment in a stroke unit has been shown to have better outcomes, as I will show shortly. Next slide. Now, these are just images to just remind you of what it looks like. Now, on the left of your screen, you see an extensive right middle cerebral arterial infarct. This patient has what we call a malignant MCA stroke. This patient has almost like the whole of the territory of the MCA is lesioned. And this patient, for example, will come down. If nothing, it will come down with disability after the stroke. And there's no way this patient will not come down. Risk of seizures, risk of dementia, risk of even death. First 90 days, mortality is very high because the stroke is extensive. Now, on the right side is a bleed. It's a bleed in the basal ganglia. If I would say in neurology that if you see a bleed in this region of the basal ganglia, that patient must have primary blood pressures in range of 200 plus blood pressure in the last 1 to 2 or 3 years. So the bleed in basal ganglia, the caudate putamen bleeds, are classical bleeds, and as time can extend, like in this case, can extend into the ventricles. When you see a bleed like this, the person, this is the basis of our Benin stroke score. We have a scoring unit that we call the Benin stroke score. This was how we found the Benin stroke score came about. Bleeds in the basal ganglia, huge bleeds like this are seen in 200 ruptured aneurysms of the charcopodal aneurysms that rupture into the ventricles, into the basal ganglia, are seen in 200, 220, 235. In a Senegalese in 2012, I saw 300 blood pressure in a Senegalese patient, 2012 in Dakar, in the stroke unit in Dakar. Highest I've ever seen was 300 plus blood pressure, something like this, a bleed, massive bleed in the basal ganglia. Next slide, still on images. Next slide. Next slide. Now, this is an MRI showing also an MCA territory stroke. This is an MRI showing it actually is a diffusion, a diffusion weighted image. The bright signals and show that it's a diffusion weighted image with bright signals, water restriction, diffusion, and this is an MRI also showing the territory of the MCA, quite extensive, involving the caudate, involving the capsule, and stretching to part of the frontal lobe on the cortex. These mice are at risk of having seizures and with a lot of disability. Next slide. Again, an MRI showing something I will mention later. You can see that this patient has if you look on the left side of your screen, you will see that there is a right cerebellar infarct. On that particular sequence is a diffusion weighted image, but on the right is a different image entirely. Is a flare, fluid attenuated inversion recovery sequence. It's not showing. This is what we now rely on in stroke neurology and say there's a mismatch. If you see this mismatch, it means that this stroke, you can predict that this stroke has not occurred for more than 4.5 hours. So you can thrombolyze this patient. This is what we now rely on, what we call diffusion flare mismatch. This was the basis of a study I will reference later. So we now see the MRI, see the advantage of an MRI. On the left side, acute DWI show that he has an infarct, but it's not showing here, which means this stroke is a recent stroke. This kind of stroke you can chase down because it has a salvageable brain that you can, there's meat here for you to chase down in stroke neurology. Next slide. Now look at this one showing a complete matching. On the left side is a diffusion weighted image. On the right side is a flare. When you see a flare matching, don't bother. This kind of patient, you cannot thrombolyze, it's lost the window. This one must be more than 4.5 hours, usually 6 hours or 24 hours. So the window for thrombolysis is lost here. This is why we say that time is brain. The first one I showed was a mismatch, and it's a mismatch that we always look after when we are looking at penumbra and umbra, which I will show shortly. But this one is a complete matching. It's a match of the diffusion weighted image, and there's a matching with the flare image. This one, there's nothing you can do about it. It's too late. It's a late presentation, and this patient has to just go through it the way it is. Nothing can be done. It's late. Next slide. Now, if you look at the image lower down, you will see that there's a bright dot towards the convexity on the left side of the lower image. That's a cortical infarct. It's like almost like a lacuna infarct seen on the left side of that brain, on the frontal lobe. But if you look at the flare, there's a mismatch here. So here is a mismatch that we always look for. That's the one that we can chase down. Diffusion, and flare mismatch. When there's a mismatch, it's a recent stroke, and something can still be done within the window of onset of stroke. Next slide. Now, that's for images. Now, just to wrap up this section, ABCD of stroke prevention. A is antiplatelet or anticoagulant. This one could pass for both primary and secondary risk stroke prevention. Antiplatelet, anticoagulants, but you must risk stratify the patient, because I see a lot of folks who just take aspirin as though it's a one-size-fits-all. No, you run the risk of bleeding if you don't have that risk. And those in atrial fluid, you also give anticoagulant. B, BP, optimized blood pressure, 130/80 or below. C, cholesterol profile, LDL-C now should be less than, we are doing less than 2.5, that's about 100. D, optimized blood sugar. E, regular exercise, avoid sedentary lifestyle. And for others, you risk stratify the patient based on what other things you present. Next slide. Next slide. Now, to the meat of today is advances in the management of stroke. I just did that as an overview so that we know what we are going into. Now, all I mentioned there, I mentioned recommendations from the American Heart Association, American Association, and European Stroke Society, and Stroke Organization, and then, of course, these are all the EAN, European Academy of Neurology, European Stroke Organization, American Stroke Association, American Association recommendation, Class 1A level, Class 1A and B alone. I chose to stay with that. Those were as incontrovertible evidence, randomized controlled trials, large ROCTs, semantic reviews, meta-analysis. There are some that are less than this, but I chose not to go into that because those ones are still, when we talk about evidence, talk about semantic reviews, meta-analysis, ROCTs are the flagship of such things. So I chose to just stay here. Now, first it begins with stroke units and ICU. Then we talk about intravenous thrombolysis. Sorry if I'm too fast, I might have a time constraint. And next, mechanical thrombectomy in large vessel strokes. And now talk about rehab, virtual realities, and robotics in rehab. Next slide. Now, stroke units, they are dedicated multidisciplinary operated wards for acute stroke care and rehabilitation. And here you have an assemblage of stroke specialists, all those who work with stroke patients, who are connected to stroke patients, who are functionally engaged, i.e. neurologists, neurosurgeons, nurses, speech therapists, occupational therapists, speech and language pathologists, and swallow experts and porters. They combine, and it's been shown from studies that patients who are nursed in such words do better, outcomes are better, both 90 days mortality and then a rate of discharges are better on the long run because the people there are used to stroke patients. Next slide. Like I said, there are dedicated wards for stroke patients and all specialist stroke patients. Maybe next slide. Repeat, next slide. Now, this is standard worldwide. Best evidence, best practice is now the global standard. It's been shown that patients who are nursed in those wards are better, come out better than the regular wards. And the advantages are many, include early detection of deterioration of stroke, discharge of patients. And then, of course, in the arrow cities that I'm quoting, I'm referencing here, number to treat on intentional ITT analysis is about 18. So that tells you too that what it stands for. That's the reference there as shown. Next slide. We in Nigeria, Alabambi and his associates published in 2022 the Nigerian Stroke Unit. Now, right now there are 5. No, maybe there are others since that time. I don't know, but let me not be too. Let me not mark too wide. But as of 2022, although I also talked to my colleagues elsewhere, these are the 5 that are known for now. First was in Benin. They have in Lasuth, UITH in Lorin, Luth in Lagos, UMTH in Maiduguri. Most of the people manning those wards are colleagues and friends, and we cross-pollinate and we talk to each other. So these are Nigerian dedicated stroke wards. If there are others in private hospitals right now, I don't know. But from published works, these are the ones that we know for now. Next slide. Now, I'll move on now to thrombolytics because of time. Thrombolytics as acute stroke care and the use of intravenous thrombolytics dates back to the 1930s, but until the NIPS trial, the National Institute of Neurology Disease and Stroke trial in 1995, that's 30 years ago, Altiplace was used in that study, and that was the first study, was a landmark study that showed that you can thrombolize the patient, eligible patients, within 3 hours of an event of a stroke, and of course, you can burst clot and recanalize the vessels, and of course, it showed that within that time frame, you can recanalize the patient, and then outcomes are better. 90 days outcome by either by Battle Index or ranking score. If you assess functional ability in 90 days, they come out better. So subsequent trials built on that. Then we have the ECASTRI trials, the European trials in 2008. That was also a revolution. So these 2 trials, 1995, 2008 trials, extended the time to 4.5 hours. So within 4.5 hours from the ECASTRI trials, you can now thrombolize a patient that is eligible. I must say that is eligible, and I'll go through criteria for eligibility. Just it's not everybody that you can thrombolize, because you can. These drugs are thrombolytics, and they have their risk. Patients can bleed both systemically and into the brain, and patients can even die faster than the stroke itself. So you must know who you are giving this drug to. It's not for everybody's use, and you must pick a patient well, and the time frame must be there. There are things that can guide you. Next slide. Now, this is the ECASTRI trials. This is a reference, New Journal of Medicine, 2008, showed this was a revolution, and many countries had to amend the use of recombinant tissue plasminogen activator, because the window now extended to 4.5 hours, as opposed to the 3 hours that we knew up to 2007, 2008. Next slide. Next slide. Now the next major landmark trial was the wake-up trial. This is the wake-up trial that first used the diffusion flare mismatch that I referred to earlier on. This trial actually was stroke in an unknown, usually for wake-up strokes. Now, like we know, most all wake-up strokes are ischemic strokes. What do I mean by wake-up stroke? A man sleeps by 9 p.m. It was well, last known well, 9 o'clock, 9 p.m. Nigerian local time. By 6 a.m., you wake him up, he's not waking up. He has a severe stroke. How do you tell when the stroke occurred? Unknown onset time. How do you tell when the stroke occurred? The wake-up trials using the diffusion flare mismatch, which I showed earlier on. If you see changes in the diffusion weighted images and the ADC map, and it's not showing on the flare, it shows that that stroke is within 4.5 hours. If it's eligible by other criteria, that patient can benefit from thrombolysis, provided the area involved is not a large vessel occlusion, because in large vessel occlusion, the area involved will be wide. I will show that as we progress. You cannot thrombolyze that patient because the area lesion is more than 1/3 of the middle cerebral artery territory. If you lesion that patient will bleed, will have hemorrhagic transmission, and probably will have issues. We have an SICH. So you don't use this drug inadvertently. You don't use this drug. You must guide your patient. Now, still on the issues of the you can see on the screen here, I'm showing you the concept of penumbra. The area that is lesion is the core. That's the umbra. That area is infected, and that's the infected core. That's what we look for in perfusion studies now. I'll show that very soon. Now, the area around the umbra is the penumbra. That is what in stroke neurology, that's what we try to salvage. So it's like a tug of war. The area that's not in or out, that's what all we do in stroke neurology is to try and salvage the area. You can see that the red area is the necrotic area. The yellow area is the penumbra. You can see the green rim is the area that is oligemic area. If nothing is done, the umbra starts to widen. And once it starts to widen, so you're losing time. So when a patient has a stroke and it doesn't present on time, what happens is that the umbra starts to widen, penumbra starts to diminish, and then of course that itself takes a toll on everything. It takes a toll on clinical outcomes, presentation, disability. So that's why time becomes an issue here. Time becomes an issue. I just showed this. Next slide. Next slide. Next slide. Now, I will skip this slide for time. This one is showing, okay, it's just showing what happens in the brain in terms of blood flow. Cerebral blood flow is at least 18 mils. Usually, it can go as high as 60 mils in the gray area, whereas the white matter area. Below 12 mils per 100 grams per minute is seen in infected areas. So this is what we see. Now, next slide. Show the next slide, please. Now, these are perfusion images showing both the core. Perfusion images actually, this years ago, this was very, this one looks so esoteric to many of us. As resident doctor, I never saw this. But usually with softwares now, matters like a rapid software, most scanners can now do these perfusion images and reconstruct images for you. And you can see the core infarct and the penumbra using cerebral blood volume, blood flow, so you can see the values, the mid transit time, that's the MTT, and the T max, the time to residue function. You can calculate some of these things and decide whether it's an umbra you are dealing with and a penumbra based on perfusion scans. Next slide. Next slide. Still again, on perfusion scans, in penumbra and umbra, there's a difference. So all we look for here are just 4 values: cerebral blood volume, cerebral blood flow, mid transit time, and the time of maximal residue function. They are known values. The software has known value. For example, the T max above 6 seconds shows that there's a T max above 6 seconds, blood volume under 30%, blood flow under 30%. So is it either with a penumbra and umbra? Sorry, back one slide. These are all what we look for. The T max above 6 seconds. You can tell from you can see the values below. Try to see the mismatch between the core and the penumbra, and then you can go after it. Next slide for time. Still again on the mismatches I told you about, perfusion scans. Next slide. Now, this what I'm showing here is the UBTH Bini, our protocol. This is recent. We have a Bini protocol now for thrombolysis. This is we developed this locally. For acute ischemic, the UBTH Bini protocol for thrombolysis and acute stroke patient, we're circulating this so that people can use it as a guide to know when to thrombolyze and when not to thrombolyze, and the criteria they are there. So next slide for time. Now we prefer to use tenecteplase. There are others, alteplase. We use tenecteplase. We prefer this because of cost. You know, we are in a resource constraint environment. We use this one is cheaper. As at a month ago, it was given about 780,000 naira for tenecteplase. Alteplase is way cheaper. Last time it was 2.2 million. So we prefer to use cheaper alternatives here, tenecteplase and the generics of it. Metalize and TNKs are known brands, but we prefer to use other brands that can do the job. 25 milligrams is giving bolus within 5 seconds, and in eligible patients, look at the ways calculated here based on maximum 25 milligrams per dose for thrombolysis. Next slide. Next slide. This is a drug. Next slide. Now, there are drawbacks of intravenous thrombolysis. If you, like I said just now, you don't thrombolyze everybody. We've shown from studies, even from studies as far as highbrow clinics in the US, from the Cleveland Clinic in Ohio to Mayo Clinic in the US, less than 10% meet the criteria for IVT. In fact, some studies say 30%. And then, of course, in large vessel occlusion, you cannot thrombolyze patients because if you do, the yield is lower in terms of result, or recanalization is poorer, and the risk of bleeding is high. So for patients who have large vessel occlusion, i.e. ICA, internal carotid artery occlusion, or M1 occlusion, or basilar occlusion, if you don't thrombolyze such, because the area usually are wider areas, you have wider areas infected, so such patients cannot benefit. So not everybody benefits from thrombolysis, even if they arrive on time. So because there are drawbacks of that based on how large, because the LVOs and large vessel occlusions don't respond, they are not recommended to use IV thrombolysis. Next slide. Next slide. Next slide. Sorry, can I have the next slide, Ilori?
Okay, so sorry, sir. I think we're having technical issues. You can continue, sir.
It's not showing on the screen.
Okay.
It's not showing on the screen anymore.
No promise. Please kindly do something. Okay.
All right. Now, next slide. Now that throws up the issue of mechanical thrombectomy. If you cannot do anything with thrombolysis, intravenous thrombolysis, what then is the option left for you is a mechanical thrombectomy. This is by best practice. So for large vessel occlusion that are not eligible for thrombolysis, after 6 hours, we resort to thrombectomy. Next slide. Next slide. Next slide. Now, so the limitations of intravenous thrombolysis led to the what we call endovascular mechanical thrombectomy. Next slide for time. Now, there are landmark studies, also large ROCTs since 2015 that have shown this. The Swift Prime trials use solitaire. I'll show one equipment just now. Here you thread cannulas, microcatheters are threaded from the femoral down to the clot. We use stent and retrieval method. Stent retrieval method, 2015. The ESCAPE trials show that patients who are thrombolized, some of them will have a bridge. You give them thrombolysis, you now go ahead and do thrombectomy, some all the way thrombectomy. They done studies, diffuse 3 trials, extend IA trials have shown repeatedly that thrombectomy is the way to go for large vessel occlusions. Next slide. Now this is a solitaire. This is a stent retriever being inside a blood vessel, trying to it dilates first, and it snaps up the clot, and there's a catheter, a larger one, like doing a trocar cannula lens, just like you do for hemodialysis. Trocar cannula, you thread this one through, and then it snaps up the clot, and then of course you can see that they recanalize. And there's a way we can measure recanalization. We have values. We talk about the 2B3 of the TICI, but I won't go into all that. But this is just to show you what it looks like. The solitaire. We have other instruments like the Mercy, the solitaire. Next slide for time. Clot removers. Now I'll round off by talking about stroke rehab because of time. There are also advances in stroke rehab. Now we're talking about fully immersive virtual reality systems. And we just recently somebody brought this to us, where a patient he wears a device, which the device will be shown shortly after this slide. He creates a fictional a patient has a paralyzed limb. You wear him a device that blinds him. Is like an ocular, like Google's. He wear a Google on the face, and he's seen an image inside that Google. It's like a TV screen. The images he will be shown are like, they look natural, but they are fictional. The man is made to do things that he couldn't do. It's like a man watching football at times and scoring goals in his parlor with his leg, whereas he's not Messi, he's not Ronaldo, he's scoring his own goals in his parlor. So you can make a man, because all of stroke is about the brain. This is where we tell people that if you're working on the leg of a stroke patient, you're not helping that patient yet, because you have not worked on the area. So when the patient starts using the limb that was not working, you create collaterals, and recovery can begin. Beyond stimulation, beyond manual, you can also now use robotics to do what manual. In fact, it's mentioned that robotics can even do better than what the manual movement can do. Next slide. Now this is what it looks like. We have this now for research in UBTH Benin, although it was personally acquired by a therapist who brought this to us recently, and we are collaborating with him now to use it for our patients. Is virtual reality I mentioned just now, creating fictional images that patient can respond to. Next slide. Next slide. Now, this is a robot. This is a robot. This man ordinarily cannot stand. The man you are seeing now is standing. He cannot stand. He is wired and held on like a crane and made to stand on the legs. That these legs are paralyzed. Robotically, this man now, these legs will be made to move and do things that he's watching himself on the screen and made to move, do things that ordinarily he won't do. Things that ordinarily he wouldn't even allow you to do. Paralyzed patients stood up, robotics, hung up, and now those legs you see can be swinging like as if in a treadmill. Those legs now can be moving as if in the treadmill, being moved by robots on the treadmill as though they are normal legs. So this is the advancement that we have seen now in rehab. Next slide. Now, where are we in Nigeria? I did it as in a tabular form to convey it easily. Now, I've talked about stroke units, just to recap, talk about thrombolysis, talk about mechanical thrombectomy, units, just to recap, talk about thrombolysis, talk about mechanical thrombectomy, talk about virtual reality, rehab, and robotics. And now in Nigeria, we now have stroke units. Since 2010, it started first in UBTH, and the mentioned centers, I mentioned them before. Thrombolysis at its infancy, but in pockets of places is now being done. There's a place in Owerri Regional Hospital where Ayahu is doing quite a lot. We are keen into that now in Benin. For Tenesti place, we now have our protocol. Last suit, Professor Ogun talked about having done quite a few, but the drawback is that patients present late. We lose that window most times, and then of course the cost of the drug is prohibitive. Tenesti place is now 780,000 latest. That's even the unbranded 780K for a man that cannot afford CT scan. I mean, your guess is as good as mine. Now, mechanical thrombectomy, none yet. I'm not aware of anybody that has done anyone here in Nigeria yet. I'm not aware of anyone. And then virtual reality, yes, we have that now. We have that in Benin now, although it's privately acquired. Robotics, I'm not aware of anyone yet. Now, stroke prevention measures with the new NAOC direct acting anticoagulants. We now use this for patients who are eligible. Coronary artery disease patients beyond those who have atrial fibrillation, we now give them the non-valvular AF. We give them, we use the apixaban, rivaroxaban. We use that for them. And for those low-dose river, in the COMPASS trials, a 5 milligram plus aspirin is been known to be a secondary stroke prevention in those who've had a stroke before, for those who have a coronary artery disease. Now, next slide. Now, to round off, I hope I've not exceeded my time. Stroke management has advanced in the last 3 decades. 1995 to date, from dedicated stroke wards or units to intravenous thrombolytic therapy, thrombolysis to endovascular mechanical thrombectomy to use of virtual reality in rehab and robotics. By best practice in Nigeria, stroke units and thrombolytic therapy are gradually being practiced in few centers, but weak institutional framework and poor public enlightenment are obvious barriers. I'll stop for now. Allow moderator to help me to feed questions. Thanks for your audience. God bless.
Thank you so much, sir. Thank you very much, sir, for this very lucid presentation. I had written before that we should post our questions and comments, but so far we have just one, sir, which I would read to you, sir. This is from Edeki Rashida. She says, "Thank you, Prof, for the enlightening lecture. Does it mean that without a diffusion flare scan mismatch, one cannot be thrombolized? That is, in the absence of any contraindications, and a CT scan done showed an infarctive stroke if the presentation is less than 4.5 hours after stroke onset." She says she's asking this because of the challenges of having MRI images done in her environment.
Excellent. I mean, that I didn't expect less from the practicing physician. Now, you could see that I was like I had like fire on my bomb of trying to rush and make up the time. Now we use the gold standard for investigation is a non-contrast CT. That's our beginning point. I know I did an overview of stroke before I talked about the advances. A non-contrast CT and CT angio are the gold standard. That's the beginning point. But most of the CT scanners that we have around here are low slice CTs. Yours truly worked outside this climb before, and I know what it means to have a high slice CT. Years ago, 2012, I was inside this climb, and a patient I wheeled to CT scan had a stroke. The CT scan was clean. I told the porters to wheel the man for an MRI. He has a huge MCA infarct in less than 15 minutes interval between the two gantries. Why? And again, if you have a low slice CT, You do. I know what it means to use a 60 slicer, 32 slicer, slitty, 128 slicer. The images won't be the same. Like asking you now an iPhone pictures and just another Android. You see that there's a difference. Now resolution becomes an issue because if you CT will tell you that there's no bleed. That's okay. You can trombolyze. There's no bleed. But there's what called the aspect score. I didn't have time for that. You can tell a man who's qualified for a thrombolysis using the aspect score or Butter stroke program and ACT score. If you don't see anything on CT, my dear, you cannot do anything. We know that here we use a 1.5 Tesla MRI. Most of us, like in Benin, the best we have here is about 60 slides. You could do that CT and nothing is shown. CT is clean. I'm sure you've seen that before. Hyperacute stroke, 24 hours, nothing seen on CT. The man has a disabling stroke or NIA stroke score. The man is down. One side is paralyzed. The man is Glasgow score is way way low. That kind of patient, you are done for. You can't do MRI. You can't do perfusion scan. All CT tells you that there's no bleed, but CT will not tell you the extent of the infarct, and you need the extent of the infarct to tell whether you can thrombolyze the man. If a man has a large MCA territory stroke and you thrombolyze the man bleeds to death, and that opens your back for litigation. So we use CT here, but most of the time the CT scanner that you have here, most times, are low. We still use it, but that's why centers that have MRO have an advantage. You can't beat it. Stroke neurology, MRI, you can't run from it. It's just too important. It helps you, it gives you some level of certainty. Because when you are thrombolizing a man, you know you are going the whole hog. You don't look back. I don't know if I've answered your question.
Dr. Etek, I think so. I think that you answered it, but I don't think she would have any. That's Dr. Edeki. I think
Well,
that the
I'll
answer
leave my mail boss, my mail email address on the chat now, so that you can also talk to me if you feel that. I'll leave my email. I'm typing my email address on the screen, so that on the chat box, so that you can, just in case you don't want to you can send me a message later. I've sent it now.
Wow, thank you so much, Prof. We appreciate that, sir. For the many comments, just saying beautiful presentation, excellent delivery, Prof. Appreciations. Then Dr. Emmanuel Oduare is asking a question. He says, as per delayed presentation, the issue, okay, is compounded by conveyance to the emergency department. And then he wants to find out, is there any possible liaison as per pre-hospital care vis-a-vis paramedics, especially, of course, for the time, the critical time between the stroke set and you understand, sir?
Something I should have mentioned maybe because of time. Now, stroke, because of the time-sensitive nature of stroke, acute stroke, ambulance drivers right now are now allowed to do some things and wheel patients straight to the CT gantry. Ambulance to CT is no longer door to CT, or we have some metrics that we use. We have door to needle time, door to CT time. Now we are talking about ambulance to CT, which means from the ambulance, without patient being going through the gamut of the air, he goes straight to CT, all to save time. Because it's been shown that for every 15 minutes, hear this, for every 15 minutes you save under that 3 hours or 4.5 hours, outcome is better by at least 4%. It's been shown. For every 15 minutes you gain within that 3 hours, outcome is better by 4%. You can improve outcome by 4% for every 15 minutes you get, and that's huge. So we are now looking for how to buy time, because the time, we have our standard. A patient who comes with a stroke right now should have the max, you have a thrombolysis injected under 1 hour. That's the best practice. CT film should be acquired in 25 minutes. 25 minutes, you have all the images ready. In 1 hour mark, you have the drug injected. But to achieve that in a system where there are a lot of bottlenecks, competing interests, somebody has to deliver. Now we used to have the ambulance service in Edo. I was told that since April it has collapsed with the new sheriff in town. Edo had ambulance service that I was so enamored of that I was praising the government then. But I'm told that it's been withdrawn since April. I didn't even know until this morning that I knew that it doesn't exist anymore. You just call 112 in Benin, they pick you up. I did a stroke research in Dakar, Senegal, 2012. Senegalese have it. There are gendarmes that will bring you to hospital by 1 a.m. Senegalese could do that. You have gendarmes that will bring you to the Center for Neurology if it's a stroke patient by 1 a.m. They have ambulance service. This can be done, but it takes, it needs you need state actors to act on this. This is beyond what we can do. So we now have ambulance drivers that can give, we have the ambulance scores, Melbourne, Los Angeles stroke score. These guys are taught to know basic things about stroke and wheel them down and make your life easy and save time. So pre-hospital care is the best global standard, Dr. Oduwari. So just to answer your question, is a global, and that's where the world is going. Thank you.
Thank you so much, Prof. We have one, I think this will be the last question, sir. This is from Dr. Benson Okwara. He's asking, what is the average hospital stay for a patient who presents to UBTH within 48 hours of stroke onset for infarctive stroke and for intracerebral bleed from hypertension?
Well, average hospital stay from our own studies, I have to reference, I have it on, but maybe I have to look at that. But we know that there's a slide on our 2015 studies. Maybe I should reference that, but we have it as a start in our work, but I don't have it by heart right now. But I have to check those stats. But I can tell you that the patient comes in, because we don't, that you have to qualify that. Is it with the patient, the stroke severity is a big factor. In the best of centers in the US, a quarter of patients who come in with severe disabling stroke, they die. Mortality is about 25% for severe strokes. Our own is higher than that, but our own is way higher than that. We are doing close about that something percent higher than what was the best global average. Now, on the long run, by 90 days, for research, we always use 90 days outcome at 90 days. The most stroke patients that will succumb will die in the first 14 days, 7 to 14 days, maximum 21 days, they die. By 90 days, you have only 3/4 of them ready. That's 25% will have died. 1 year after, for those who have severe strokes, so not just minor lacunar infarct or TIA, 1 year after, you're going to have that 1 year after, you still have about 3/4 of them being alive. 75% will be alive by 1 year after. But in 5 years, from most studies, half of them will have been dead, because a lot of them have other comorbidities, cardiovascular, i.e. large hearts. They succumb from heart-related conditions too. It's so ischemic heart disease, or hypertensive heart disease, or heart failure. So we say that of those left behind, about 40% will be chair bound. I mean, they will have a ranking score of 3 and above, which means they are not independent. Stroke recovery is judged by dependence. So just to go back to your question, we have to reference our own study. We have done something on that before, where we looked at 334 patients with strokes in 2015, which I referenced before. But we have not. But I can tell you that nobody does less than 6 weeks in severe strokes, disabling strokes, a more to 6 weeks in our center. And worse still for bad ICH, intracerebral hemorrhage, it can be longer than that. Thank you.
Okay, sir. Thank you so much, Prof, sir. The discussions, I see that more questions are coming, and this discussion can go on and on and on. But for the sake of time, we would have to round it up at this point. So once again, sir, we really, really appreciate you, sir. It's a huge privilege to, again, sit down under your tutelage, sir. May God bless you richly, sir, in Jesus' name.
Thank you. The honor is mine. Thank you.
Thank you, sir. Before we wrap up, I want to recognize Dr. Henning Ngalato. He's the National Professional Development Coordinator, and he's with us. We're so happy to have you, sir. I will hand over to him. He's going to also introduce other generals that are present with us. So, good evening, sir.
Good evening. Thank you so much, Dr. Ebabon. Thank you so much, Ma. Thank you so much, Prof, for this very enlightening presentation. We're very, very privileged and excited to have been part of the audience. Thank you so much, Prof. Without taking much of our time, just to appreciate the leaders within the House, members of the governing board with us. We want to say thank you for being available. The Deputy CEO 1 and 2, Drs. Aye and Dr. Alex Etubi. We also have the VP West, Dr. Simeon Olateju is also here with us. Thank you so much, sir, for being available. We want to thank also the chair of the board of CPD, Professor Femi Ogundipe, who is also in attendance. Also in attendance is the president of the CMDA Students Covenant, Osondu. Thank you so much for being also on the call. And our chapter chairman within the Western Zone and every other person on the call. Thank you so much for the privilege, and thank you so much for being in attendance and making this a worthwhile presentation. Thank you, UBTH, for this beautiful hosting. We look forward to the next hosting. So I want to hand over to yes, I will want to hand over back to the moderator. Thank you once more. Thank you, Prof.
Thank you. Thank you, sir. Thank you, sir.
Thank you, sir. Well, we'll be rounding up, but one of our leaders in CMDA UBTH to round up. Let me invite the vice chairperson, is in person of Dr. Ohenhe, to please round up with closing prayers. Thank you, ma'am.
Thank you very much. Good evening, everybody. I want to join others to thank profusely my teacher, Professor Frank Imarhiagbe, for making this presentation very easy for us as a chapter. From the time we contacted you, there was no hesitation. You gave us every support we needed to make this CPD a success. Thank you very much, sir. May God richly bless you.
Thank you, amen. The honor is mine. Thank you.